procedure, but it's actually not. Most implant companies have some removal systems. Some are much more well-engineered than others. But as long as you have meticulous planning of where you're going to put your pathway and how you're going to take them out, they're not that hard. Implants do matter. I've revised, I think, just about every implant out there. And, the screw types are easier to take out for some obvious reasons. These triangles are also pretty easy to remove. They do have a very good chisel removal system out there for them, which is great. These posterior allografts, which I showed in one of those slides before, are easy. You just ignore them and blaze right through them. And then these posterior-based cages, they're placed pretty caudal and posterior, which leaves you room in the anterior SI joint. So we'll go through a couple of case examples about how we do it. This is a patient that has some screw type dowel devices, 38-year-old Phi Ed teacher, chronic pain, 2 years status post the fusion surgery, and really never had any relief, and was actually a little bit worse. So she gets the standard eval. I get the flamingo views there on the bottom to look for pelvic instability, standard inlet outlets and a CT scan, and get the injection. Injection's well done. Gets her from a 7 to a 0. So I offer her surgery and we get the removal system. These screw type devices, if they are ingrown and just won't budge, I always have trefines on standby to over drill them. These are, I believe a 12 millimeter outer diameter. So I use a 12.5 millimeter trefine. I really am a fan of these metrics tubes for MIS and the quadrant retractor system to help see. Then I sit down with a headlight and a stool and use some long instruments to help expose and directly.
Worauf hast du heute Lust? Pizza, Burger, Sushi?
Look at the implant. This is my template. You can see on the right side, that's my proposed trajectory for my revision implants. And then I recannulate the devices, drill through them to help break up any bone with inside. The top one came out easy. The second one was pretty ingrown. So I was not coming out easily. So then we dilated, have that quadrant retractor system that you guys know. And this is the trefine going over it. And the trefine loosens it up. And then you can extract it out with the standard removal tool. This is me just doing this turns into a routine primary fusion surgery. Put our device in there. This scrapes around and decorticates the SI joint and put a little bone graft into there, which is a combination of allo and autograft. And then put the screw across, which gives a nice compressive force to the ilium. And then we neutralize that force with an anti-rotation screw as well. And again, here's her crossover sign. She gets an 8 down to a 0. Her promise scores are improving, and she does remarkably well with a solid fusion mass between the
Hello everyone, my name is Jochen Breuer-Steinbach. I'm the Marketing Director of RevoSpine, and it's a great honor for me to introduce our Percoline product line to you today. Percoline has 4 different systems, mainly for facet and SI joint denervation and intradiscal pathologies. With our radioblader RF 4 MHz. 4 MHz, it's a huge difference to other systems available in the market, because it's a high frequency, and this guarantees safe and precise coagulation and ablation of tissue. We also have a unique designed electrode. It's called tip control. With this tip control electrode, you also have the possibility to angle the tip of the electrode, and you can work in a more wider range in the operating field. It's also a unique handle design. That means you can turn around the electrode tip 360 degrees quite easily, and you have a safety feature because we have this thumb ring. So it's also another feature for this electrode, which helps to work really precise during the treatment. I have here a study of Professor Wojciechowski from Berlin exactly about this 4 MHz endo joint denervation at the SI joint. The huge difference is when you work with an endoscope, you have the possibility to see all the anatomic structures, to inspect and identify all the anatomic structures, which you can see here in these pictures. That means you can be really sure that you are calculate on this part of the SI joint really precise for a long-lasting denervation. This is what shows in this study. So it's a really, really important study, and evidence of this. The results are really good, especially when it comes to long-term results. So with the endoscopic denervation perculine endojoint, you have the possibility to inspect the operating field, to visualize your anatomical structures, and to be really clear and precise when it comes to the SI joint denervation. This is how it looks like. So you work with an endoscope, and of course you have also the possibility to work with small working instruments like scissors or rongeurs to do a biopsy or something like this. So to even more than just the denervation of the joint. So this is all possible. And of course, as I mentioned, you have the great advantage that you visualize all the things you do, and of course you can see your working instruments, your electrode, where they're working, what they're doing inside the patient. This is perculine joint. It's the same principle, but without visualization. So here we don't have an endoscope. We have a simple sleeve-in-sleeve system with a nice irrigation system to make sure the RF is working well. Everything here is reusable. So the full system is a reusable set. You can see here in the set. Also here you have the possibility to work with working instruments like rongeur and scissors to do biopsy and things like that. So it's a really efficient way for precise facet and SI joint denervation. For more information, please visit our website, perculine.com. Don't hesitate to contact us for more information or for a clinical trial. And please go to our YouTube channel. Also here we have nice information and videos about this procedure.